So good evening, everyone. Today, 19 June is the World Sickle Cell Disease. And after all the positive feedback that we got on the World Thalassemia Day, we thought it is prudent that we also discuss sickle cell in a much in-depth analysis as we did for thalassemia. Incidentally, the Ministry of Tribal Affairs under the Ministry of Health and Family Welfare has held multiple programs all throughout the country, especially in those districts where sickle cell disease is prevalent, to spread awareness of the disease. And I'm proud to say the Society of Fetal Medicine got an invite as a stakeholder to participate in spreading the objectives of this mission. And in fact, they had a large sickle cell disease conclave in AIMS all throughout the day, where the Ministry of Tribal Affairs was the guest of honor. So we all know about sickle cell. We deal with it commonly, but seldom do we know in depth about what the programs are and how they benefit. And SFM being a large stakeholder now, I thought it is prudent that we as members enlighten ourselves to what is happening in the country pertaining sickle cell disease. So, like thalassemia, this is going to be an in-depth analysis of sickle cell. And to invite the first speaker, we begin with Genetics of Sickle Cell Disease by Dr. Bhavna Agarwal. Now, Dr. Bhavna Agarwal is a clinical geneticist um, at the Yashoda Hospital and Suneri Devi Hospital. She has done a DM in medical genetics from AIMS, and she has done her. Um, she's been in Lady Harding for most of her postgraduate life, and she has her field of interest lie in lysosomal storage disorders, prenatal genetics, and neurogenetic disorders. So, to begin with the genetics, may I invite Dr. Bhavna Agarwal, please?
Thank you so much, sir. At the outset, I would want to thank you, SFM, Dr. Khurana, you, sir, and Dr. Reema, to invite me to talk about a disorder which is so prevalent. Still, India is facing, to eliminate this, India is facing challenges. So, without wasting time, let me share my screen. Is it visible now?
Yes.
Is it? So let's go into the depth of genetics of sickle cell disease. As sir mentioned, before going ahead with what is happening around in terms of policies and programs, let's go around the molecular defect. What is happening in the body in sickle cell disease? So before going into sickle cell disease, we all know that we have majorly three hemoglobins: hemoglobin F, A2 in the body, which we see when we are ordering HPLC. Why I'm talking about these three are because in the HPLC, which should be done in every pregnant female to see about thalassemia, sickle cell, and other hemoglobinopathies, we should be knowing the normal percentage of the various forms in the adult life. So HbF is usually less than 1%, HbA is usually 92%, and HbA2 is usually 2 to 3%. And we should be knowing that it is a tetramer which forms the hemoglobin. So in HbF, we have alpha 2, gamma 2. Why it is important is because we have therapeutics which are targeting to increase HbF to take care of the fact that HbF will ameliorate the dysfunction happening in sickle cell. So again, we have HbA2, which is alpha 2 and delta 2. So basically 2 chains of alpha and 2 chains of delta. And why it is important is mainly in thalassemia, which is beta thalassemia, where we see an increase in HbA2 in beta thalassemia trait. So after saying this, let's talk about hemoglobin disorders. So before knowing about sickle cell disease, we should be knowing that there is something called as structural changes in the hemoglobin, which is called as hemoglobinopathy, and there is something called as expression of the globin gene, which is decreased. So that is called as thalassemia. So usually we have two forms of thalassemia, alpha and beta, when we have alpha chain defect or beta chain defect. But when we have a structural change in the hemoglobin or the globin protein chain, it is called as hemoglobinopathy. So today the topic which we are discussing is actually a hemoglobinopathy. We should not call or confuse it with thalassemia, though we are using the HPLC to diagnose it. We are doing the HBB sequencing to pick it up, but it is a type of hemoglobinopathy. So important points are, we should be knowing and telling everyone the difference between a screening test and a diagnostic test. So screening test, as the government is trying really hard to put hands all together to eliminate the things. So screening is basically when we screen the community and not labeling the diagnosis or providing genetic counseling on that basis. So screening is, you are actually screening the healthy population and taking the people out of it. When we have a trait, be it a thalassemia or sickle cell, we know that it is usually asymptomatic. Why usually? Because the topic today is sickle cell, and sickle cell trait, we say they are usually asymptomatic. But there have been papers and there have been studies which have quoted that even in a sickle cell trait, when they are exposed to high altitude, or if they are exposed to severe deoxygenation, they will manifest with sickling episodes and hence the symptoms. And also they are predisposed to a term called as sickle cell trait nephropathy. So not all the traits are totally asymptomatic. That is why I have used the word usually asymptomatic with no complaints, and the screening is usually done by HPLC or electrophoresis, right? There is a term called as silent carrier, more so in terms of beta thalassemia, so I'm not discussing this. But silent carrier is when we have a mutation, but it is not manifesting in the HPLC, right? And we always do the parental screening by HPLC before putting a prenatal or a needle in the fetus. So a parental carrier screening or a parental molecular diagnosis should be with us before putting a needle in the fetus, right? And also very important is, when we give a blood transfusion, we know that HPLC should not be taken as a reliable method to pick it up, because the RBC span is almost 120 days, and genetic testing should be offered in such scenarios. So now moving on to further, sickle hemoglobinopathy. So rather than calling it as a sickle cell anemia or sickle cell disease, let's talk about the usual terms. Historically, what we know is sickle cell anemia has been used to describe persons who are homozygous for this particular change, which I am going to talk about. At codon 6, glutamic acid, which is a non-polar acid, is being converted to valine. Valine is a negatively charged acid. So there is a change in the morphology, and that is why we call it as a structural change, which is leading to polymerization and hence the symptoms. Or at times, persons with HBS and beta naught thalassemia, which is severe type of thalassemia, is also called as sickle cell anemia. But mind you, there is a term called as sickle cell disease. So we are not just looking for the HBS allele, we are actually looking at all the other alleles also. So it is one of the allele will be HBS to call or qualify for sickle cell disease, but the other allele can be HBS, HBC, HB, beta, and the other forms also, like lipor or other forms, right? So with this, we are clear that when we are giving a prenatal diagnosis or when we are actually screening a proband, we need to talk about all the other hemoglobinopathies other than the HBS also, because we need to actually find whether the person is suffering from sickle cell disease or homo for sickle cell disease, which can be called as sickle cell anemia. So basically what is happening is, when we have an abnormal HBS, there is a abnormal change in the beta globulin chain, which is leading to deoxygenation stress and alteration of the function and the structure of the HBS. So eventually what is happening is, these deformed RBCs, they are less flexible, and also they are highly adhesive. There are certain changes which are happening in the RBC itself, which is predisposing it to adhere or having adhesiveness to the capillaries, and hence the major culprit other than the anemia is this vaso-occlusive crisis, which is happening because of the adhesiveness of these sickled cells, right? And age of presentation can be any age from infancy to adulthood. So it's a genetic disorder which has a basis from birth, but it can manifest later on also. And the severity is variable. We will see there are number of factors which will decrease the severity of the sickle cell disease. So with this, we all know that the chromosome is 11, on which we have the HBB gene. And we all know that there is a sickling, there is a change in the shape of the RBCs, there is deformation, and ultimately this will occlude the vessels and will lead to veno-occlusive episodes. So before talking about any disorder, to call it as a public health problem, the burden needs to be seen. So this particular paper from Nature has taken the world, and global incidence has been shown. We can see here that India falls here. Somewhere the prevalence is almost 51 to 100 per 1 lakh birds. So the major origin is in the Africa. So we can see here that the Africans, the prevalence is very high, as high as 1700 per 1 lakh births. So, and India lies here. So in India also, this particular diagram is very important because we try to screen everyone, but we should not forget these high prevalence areas, the belt, which is called as sickle belt. And we can see here this green is, this red is for the sickle cell belt. The major area is the central India and the southern India. And in central also the Gujarat, Maharashtra, Chhattisgarh, these are the areas where we have more of sickle and sickle allele, which is prevalent. And the prevalence can be as high as 40% also. If we know about this particular area, this is southern India, Tamil Nadu, and the Kerala part, where also some tribes are there which have more of sickle. So, and we all know that there is HBD Punjab, which is more in the Punjab area, and this northeast, we have predominant form of HBE. So, this particular diagram or the map of India is showing the prevalent areas. So, we should not forget screening at least those areas and the populations. So, what is happening from the molecular level? So we all know that we have two chains. So this one chain, the second chain. So if we see here, this is a tetramer of the hemoglobin. We have two beta chains and two alpha chains. So this is the normal tetramer, right? We have no change. This is a clean chit in both the chains. When we see this, we have a change here, which is at the 1, 2, 3, 4, 5, 6, 6 position. We can see here that there is a change from A to T, which is leading to the change from glutamic acid to valine. So one of the allele is normal and the other allele is showing this change. So this person would be sickle cell trait or HBAS, right? We can see here, this is normal. There is no sickling. There is a hybrid hemoglobin because there is just one of the allele which is abnormal. But when we go down these forms, these three forms, we can see here that there is abnormal morphology of the RBC when it is deoxygenated, and it is a reversible process. Very important to know. So sickling is happening only when we have deoxygenated condition, and it is a reversible process. As long as there is deoxygenation, sickling will be there, polymerization will be there. So our therapies will also promote the oxygenated states. So as and when we have a pathophysiology which is very clear, the therapeutics will be targeting that. So if we see here, there is a sickling because there are abnormal forms. Both the alleles are abnormal, and we can see this polymer which is being formed. And typically in polymerization, this is a 14 chain polymer which is formed. And you can see here sickle cell anemia, HBSC, HBS beta, all are sickle cell disease. So here we have a change which is valine and valine on both the alleles. So this is sickle cell, both the alleles are sickle cell. Here we have a change which is at the same position, sixth position, but now the change is lysine and it is hemoglobin SC because one allele is S and one allele is C. And now here the change is we have a S allele and other allele is having beta naught or beta plus allele, which is thalassemia trait, right? So with this, I just want to tell you that we have a nomenclature. Usually in the reports, people forget to write sickle cell allele or sickle cell mutation. So we can remember this number, which is C.20 A to T. So basically, this is the codonic position, and we were talking about this is the nucleotide position, and this is the codon position. So we all know that we were talking about sixth codon. So when we see the nucleotide position, it is C.20. This is very important because sometimes the reports say C.20 to T, C.20 A to T. So it is a homo sickle cell disease, right? So if the change is glutamic acid to lysine, we have seen already the same codon position, but the different change, it is leading to HBC. E is the same change at different codonic positions. So it is at 26th codon. D is when we have at the codon 121. And similarly, when we have the similar codon change with different amino acid, we have HB Arab. So it's very simple to remember. I would say at least HBS and HBE are something which usually come up in the reports because of the high prevalence. And we can remember C.20 A to T for HBS and C.79 for HBE. So with this, there is a concept of different haplotypes. We all have seen that we have a single point mutation, which is at codon 6. But still we see the severity is very different. What we see in the African area is not replicated in the Indian scenario. Why? because there is a concept of different haplotypes having some significance in the phenotype. So what happened in the evolution, a same change, same mutation happened 5 different times in the evolution. So when it had happened in the Central African Republic, different areas, Benin, Senegal, Cameroon, and Bantu. So what happened is we had different haplotypes. So the common mutation was there. However, the adjoining areas. So haplotype is when we have adjoining areas also around the mutation, which were different. So mutation was common among all the fives, but the adjoining areas were different. So we have different haplotypes. So these haplotypes were considered more severe. And in India, we have something called as Arab Indian or Asian haplotype. So basically, this particular haplotype was found to have milder presentation. Why? Because it was seen that the adjoining areas, because of the adjoining areas, the HbF level was high. So when the HbF is high, we have decreased severity of the sickle cell disease. So this is I find it very interesting. The same mutation, different phenotype because of the evolutionary change. So as we know that a lot of work has been done to generate Indian prevalence, because we cannot rely on the West data because our population is actually very diverse. So first case was described in Nilgiri Hills of northern Tamil Nadu. So southern India was the first area in 1952 where we found the first case. And then we all know that the Deccan Plateau of central India, north of Kerala and Tamil Nadu, they are the hotspots. And the frequency of sickle cell trait, it can reach up to as high as 35 to 40%, which is very, very high. So, as we can see, 40 out of 100 would be having sickle cell trait. So, prevalence according to different surveys, the least is in the northeastern area, which is 0 to 18. And as we go down towards south, it has very high prevalence, specifically in the areas of the central India, which is Chhattisgarh and Madhya Pradesh. So, this is very important to have strategies from the government also, where first to pick up the high prevalence areas, work on those, and then we can think of the universal programs happening in India. So another concept is, during our MBBS time also we used to get this question, malaria and sickle cell. So there is a misconception then that when we have sickle cell, the malaria will be less. It's not that. The sickle cell is not immune to get infected by malaria. The malaria parasite will infect the sickle cell, but there is a concept of heterozygous advantage. The term is heterozygous advantage. So the heterozygous stage for sickle cell, which is AS, are relatively protected. They are not protected from the infection. They are protected against the severity. So they'll not die of cerebral malaria or the other complications. However, when we have a sickle cell anemia, they are highly susceptible to the lethal effects, because already the anemia is happening, and we all know that in malaria, again, anemia is happening. So we should not take it as synonymous with malaria and sickle cell advantage. It is the sickle cell trait which is having advantage over malaria severity, not the infection. So how people have proposed different theories. So this is Haldane theory, which has propagated this thing, that when we have a malaria infection, there is deoxygenation which is happening in the infected RBCs. So all we know is now sickle cell, there is more sickling when we have deoxygenation. So when we have deoxygenation because of the infection of the malarial parasite, there is more sickling and eventually more sickling, and this particular infected RBC will get phagocytosed by the macrophages. So this is the infected parasite is being killed and not leading to severity. So this is very important because the history and the evolution is very important in genetics. So vis-a-vis, when we have a normal AA gene, there is a dissemination of the malaria. The merozytes are disseminated in the circulation. So another concept is, after knowing the molecular diagnosis, we should talk about the newborn screening also, because why and what why we are doing it is because there are treatments which can actually change the trajectory of the disorder. So in this particular newborn screening, it has been done in Ghana, specifically in Ghana and US. US, all the 50 states by 2006 had a newborn screening for sickle cell disease, and they were using HPLC in the eluate of the DBS. So we all know that pilot projects have been done specifically in areas with high prevalence, Gujarat, Maharashtra, and Chhattisgarh, and they've seen that the prevalence is as high as 2 to 40% in the various newborn screening programs. So what next? Once we know that the patient is having a sickle cell disease, so if we start the penicillin prophylaxis timely, which should be up to 5 years of age as soon as we diagnose the patient, and also the immunization against the encapsulated organisms, specifically pneumococcus and H influenza. So we will decrease the mortality by a significant number. So main advantage is to start the prophylaxis and decreasing the infections and hence the mortality, and also to prevent the major cause of death, which is sequestration crisis in the children. So when we talk about mortality and morbidity in sickle cell disease in children, it is different from adults. So in adults, basically the mortality would be mainly because of the pulmonary complications. They'll not die of infections. They'll not die of sequestration reactions or crisis. They'll die of stroke. They'll die of pulmonary crisis. They'll die of other disorders, CKD, CCF, right? So we are targeting the children here in the newborn screening. So pathophysiology, as we all know, that we have two major changes which are happening. First is chronic hemolysis, because as we all know that this normal RBC takes the shape of sickled RBC in the deoxygenated phase, and we have a polymerization which is happening because of the deoxygenation, right? So main thing is tissue ischemia, which is leading to a cycle. It's a vicious cycle. There is ischemia, there is reperfusion, more damage, more reactive oxygen species, and more ischemia, and it's a vicious cycle. And chronic hemolysis is just add on to it. So people talk about two phenotypes. One is vaso-occlusive subphenotype, other is hemolytic phenotype, right? So we may be having excess of one phenotype over the other. The severity may be different in different individuals. So if I talk about this complex diagram, two things to take away from this diagram is, when we see this diagram, we have a polymerization which is happening. 14 hemoglobin molecules, they polymerize. So ultimately what is happening is, we can see here very important three words: alpha thalassemia, HbF, HbA. So why I'm talking about this is because the therapeutics as well as the genotype is very important, which is determined by these factors. So if we have a HbF, which is excess, it will inhibit polymerization, right? If we have alpha thalassemia, so in alpha thalassemia, we will have decrease of alpha chains. So hence a decrease in the HbB, as in the hemoglobin which is there. So ultimately the polymerization will be less. So when we have a concomitant alpha thalassemia, the severity would be less. When we have a concomitant HbF, which is hereditary persistence of the fetal hemoglobin, the severity would be less. And also, when we have a deoxygenation, which is mainly when we see a decrease in pH, as I've told in malarial infection also, there is acidosis, decrease in pH. When we have all this, there is actually a lot of damage which is happening to the RBCs also. There is specific Gardos channel which will lead to loss of the potassium out of the cell, and ultimately there will be a dehydration in the cell and the change in the RBC, which will lead to decreased lifespan. It reduces by 1/100th. Usually the lifespan is 120 days, and in RBC, which is sickle RBC, it is 7 to 12 days. Very, very important to note this, right? So this complex diagram, I just want to tell you that two phenotypes are there. One is vaso-occlusion is happening. Other is because of a lot of inflammation around and a lot of addition to the endothelium. All this is happening because we have targeted therapies now for all this. So we have L-arginine supplementation, because we two things. There is a NO deficiency, which is functional deficiency. So there is a spasm, there is a lot of inflammation happening. So the manifestations, again, because as I said, it can manifest from infants to adulthood also, but life expectancy is drastically reduced, which is usually 72 years. It is 42 to 48 years. The females, they have an advantage over here, 48 years in females. This is a rough idea, 42 years in males. And as we can see, the manifestations in the childhood are different from the adulthood. So in child, usually we see anemia, jaundice, splenomegaly, pneumonia, meningitis, dactylitis, which is swelling of the limbs because of the bone infarction. As the age increases, we have stroke, we have again priapism, pain crisis. Again, when we have more, because by this time, autosplenectomy would happen. Because of the spleen infarcts happening, because of the vaso-occlusion, the spleen will go. So it's very hard to find a spleen in a child which is more than 5 years of age. So it's not that it is not sickle cell. It is still sickle cell. It has undergone a autosplenectomy, right? So as it happens, we have decreased manifestations like this. However, we have more of the vaso-occlusive and the inflammation phenotype, which is now predominant. And we have CKD, we have retinopathy, we have avascular necrosis of the bone, specifically femur bone, and pulmonary hypertension. So every organ, it's not just the RBC, is impacted. We can see here we have chronic complications, we have acute complications. So molecular test, very, very important. The right choice of the test is something we are looking at. So we all know that sickle cell disease or sickle cell anemia has a point mutation, which is at codon 6. But saying that, when we are talking about sickle cell disease, we know that it can be SCAS, it can be SCSC, it can be HBSS, it can be HBSD. So all of those are sickle cell disease. So now allele specific PCR, which is ARMS PCR, can be performed where we are actually targeting only one mutation because we are having primers for that. So it can be done for HBS because we all know that it is a point mutation. Similarly, it can be done for targeted mutations. Now we have seen HBC also is a point mutation, HBD is also point mutation, HBE is also point mutation. Similarly, we have to perform different ARMS PCR for all of this. However, when we do HBB gene sequencing, all our point mutations, this will actually screen the entire HBB. And the notorious thing of HB beta thalassemia, which can have mutations pan HBB gene, will be picked up. So we will be able to pick up HBS beta also by doing this. So if sickle beta thalassemia disease is suspected, like I said, consider HBB gene sequencing rather than just the targeted sequencing, which is ARMS PCR. Also, just to mind you, alpha thalassemia is basically deletional phenotype, and the choice of test here would be a test which will pick up the deletions. So MLPA, which is actually picking up the deletions, duplications, or gap PCR is the choice of test here. We have less of the point mutations in alpha thalassemia. Why? Again, because alpha thalassemia, as I said, it can be actually a confounder, or I would say disease modifying phenotype in sickle cell disease. So genotype phenotype correlation as a geneticist is very important. As I mentioned, persistence of the expression of HbF would lead to decreased severity of the sickle cell. And if it is up to 50%, when we have homo HbF with sickle cell, the severity would be so less that it will be very mild, very, very mild. So sickle cell hemoglobin C is one. Usually in India, it's very less seen. So probably sickle cell S and C, I have also seen very less, and the prevalence is also very less. But they are particularly prone to have retinopathy and avascular necrosis because of the mechanisms which are still unknown, right? So this particular table I find very important when I get a patient in my clinical practice also. So when we have a homozygous state patient, there is no need to go and look at the literature. This can be remembered. When we have a homozygous state, we are talking about HBS today. So when we have a homo HBS, which is HBSS, it is called as sickle cell disease, right? Others are not important pertaining to the topic, which is the topic of discussion today. But this compound heterozygous state, if you talk about the lower 1, 2, 3, 4, 5, 6, 7 phenotypes, we are talking about sickle cell disease. So this is also sickle cell disease. This is also sickle cell disease. This is also sickle. This is also sickle. This is also sickle. But you can see the severity. Usually HBS mild beta plus plus. When we have some production of beta chain from the other allele, it is mild sickle cell disease. So prenatal would be offered in all the forms, above 5 forms, right? Vis-a-vis, if you talk about specifically, we have queries when we have HB, E beta or D beta, right? D beta, no clinical problems, no intervention in the form of prenatal. However, when we have E beta, again, it will manifest and you can offer prenatal. So this particular two diagrams are important, or I would say tables, to actually guide the patient for prenatal. So general management, after we have picked up, we have suspected, we have picked up the mutation, we have advised the prenatal also. We have to see the patient holistically also. We have to advise for the index patient regular transfusions. We, despite of the fact that it is a hemolytic anemia, we usually don't do regular transfusions because the more the transfusions, more alloimmunization. So we have reserved the transfusions for certain indications, like we have stroke, we have chronic transfusion things for stroke. We maintain a diary, we supplement folic acid because there is a high turnover for the RBCs, hemolysis happening. We give the vaccinations, we monitor the growth, and also because of the pubertal changes, delayed puberty happening in sickle, we monitor the puberty also. So prevention of the primary manifestations is very important. You have to give the education properly, maintain hydration, very, very important. Avoid extremes of climate, avoid triggering complications, like I mentioned, monitor for the signs and symptoms for acute medical intervention. A diary should be given. All the family members should be told about the manifestations which can happen. And also, we have to seek the help of community support groups, very, very important in genetic disorders, because people will talk to each other and will get to know what services are there from the government or the private groups which can be utilized. And also, we have a number of therapies. I would say this particular hydroxyurea is the main therapy, and we all know that it works by increasing the HbF again. So we are targeting either by a gene therapy also, which is now again a landmark thing which has happened in 2023. We have now two FDA approved gene therapies. What they are doing is they are actually targeting the HbF only. They are inhibiting, or I would say edit the gene which is inhibiting the formation of HbF. So this Casgevy and Lyfgenia, these are the two gene therapies which are now there and has been approved. So counseling of the family at diagnosis is very important. Like we do in any genetic disorder, you counsel about the nature of the disease, you counsel about the timing, intensity of transfusion regimen, you talk about the importance. They should not be thinking that it's one time thing. You have to tell that they have to be compliant to the medications and treatment. And also, not to forget, you have to screen the siblings and the family members. Also explain the available new treatment options. A number of them, they are available in trials. Patient may be eligible for enrollment in those. Timetable of the evaluation, very, very important. We have a beautiful timetable for the surveillance guidelines. We all know that the cerebral thing, there is a concept of monitoring the TCD velocity, which is transcranial Doppler, monitoring the MCA velocity or internal carotid artery velocity, and we actually predict whether stroke can happen or not. And the treatment would be changed depending on the velocity. When it is more than 200 meters per second, the treatment would be different. So 2 to 16 years, we monitor with this TCD. We have a concept of screening for retinopathy from 10 years of age onwards, and also reproductive options. Once a sickle is born in the family, if second is born, then it's a failure, at least on the part of a geneticist also, or any person who is dealing with that family. You have to explain the concept of, actually, it's called as autosomal recessive, but frankly speaking, it is actually co-dominant. As I mentioned, sickle cell D, S, sickle cell SS, both are manifesting independent to each other. So you can explain with this diagram, there is a risk of 25% when we have both the couple as traits. So with this, we all know that prenatal diagnosis should be offered only and only when we have a definitive molecular diagnosis. So these scenarios can be there when we have both the HBB pathogenic variants. I've used the word now HBB pathogenic variants because it's not just sickle cell allele, it is actually HBD, E, beta, anything which can lead to sickle cell disease when inherited with one defective sickle cell allele. So have been identified in an effective family member. And other scenario can be when we have a genetic status of the parent which is known, because one parent may have a non-HBS HBB pathogenic variant, which I said, or biallelic HBB pathogenic variant that can interact with HBS to cause a sickle hemoglobinopathy. So the term of sickle hemoglobinopathy will cater to all the HBD variants which we have talked about, specifically HBC or beta thalassemia. The genetic status of the parents must be defined before offering prenatal diagnosis or testing. So with this, I would want to end my talk, and thank you so much.
Thank you, Dr. Bhavna, for that informative talk. We now move on to our panel discussion. If I could be given screen sharing.
Ma'am, I've stopped sharing.
Yeah, thank you. So good evening, everybody. Thank you for joining. And we all understand that today is the 19th of June is the World Sickle Cell Day. Globally, we're celebrating it. And sickle cell disease, we understand, is a rare, debilitating, life-threatening blood disorder with significant unmet needs. And most disturbing fact is that India is a capital as far as sickle cell disease is concerned. Society of Fetal Medicine observes the World Sickle Cell Day, and we all collaborate to work for a common cause. We have a very, very illustrious panel with us today, and I would like to welcome each one of them. I take this opportunity to welcome Lieutenant General Velu Nair, Service PVSM, AVSM, VSM. He is presently Head and Chief Consultant of Hematolo-Oncology at BMT at Apollo Cancer Center, Apollo Hospitals, Ahmedabad. He's been a phenomenal in his academics, a gold medalist in MBBS, MD from the Armed Forces Medical College. He's been to the King's College, London, and Stanford Medical, USA. He has been the Director General of the Medical Services, President's Honorary Surgeon. He's been Dean of the prestigious Armed Forces Medical College, President of the National Society of Hematology and Transfusion Medicine. He's been chairman of the Accreditation Committee of NABH, and of course, also the co-chair of the various committees of ICMR, DBT, DRDO, and NABH. He's presently President-elect of the National Academy of Medical Sciences, NAMS, New Delhi. He's been the founder member of Indian Myeloma Academic Groups, elected council members twice, and he's got lots of feathers in his cap. I can just go on and on. We welcome you, sir, today to this panel. We welcome Mrs. Vandana Gurnani. Ma'am is a master's degree in economics from the prestigious Delhi School of Economics, Delhi University. She's been in the Johns Hopkins University. She joined the prestigious Indian Administrative Service in 1991. She's currently posted as the Additional Chief Secretary of the Government of Karnataka at the Karnataka Bhavan, New Delhi. But what is phenomenal has been her work in the National Health Mission in the capacity as Additional Secretary to the Government of India. She led the initiative to achieve the universal health coverage through comprehensive primary health care along with health systems strengthening, and also, more importantly, the Pradhan Mantri Ayushman Bharat Health Infrastructure Mission. She's extremely conscientious and very, very hardworking. She's been instrumental in designing and implementing the 15 Finance Commission grants to panchayats, reproductive and child health. She's worked hugely on that work. We really welcome you, ma'am, to today's panel. Ashok Khurana, sir, needs no introduction. We are here because of him. The Society of Fetal Medicine is what it is today, for he has been the founder. We welcome you, sir. It is his vision that we in the Society of Fetal Medicine should work for a common cause and should observe the World Sickle Cell Day. Thank you, sir, for initiating this program. We welcome Dr. Kaustubh Giri. Dr. Kaustubh Giri is a senior Indian Revenue Officer. He completed his MBBS from Seth GS Medical College. Since 2013, he's been working in the central government as the Indian Revenue Service Income Tax Office. He's been involved there, but now he's moved on to the Ministry of Health and Family Welfare since September 2023. More importantly, he's been involved in the NHM Policy Division and NHM Finance as a role as Deputy Secretary in the ministry. We welcome Dr. Rahul Kataria. He's the professor and head of the Department of Transfusion Medicine at Amrita Hospital, Faridabad. He's a very dynamic blood transfusion specialist, young investigator awardee, awards of excellence, and numerous awards to his credit. Dr. Chinmay Umarji is a very young and dynamic fetal medicine specialist from Pune. He's been doing phenomenal work in the Society of Fetal Medicine. Currently, he's the president of the SFM Greater Pune chapter. He's always smiling. We welcome you all. Dr. Girish Patel, he's another very, very hardworking member of the Society of Fetal Medicine. He's been the secretary of the Gujarat chapter of SFM, and he did take Gujarat SFM chapter to different levels during his tenure. Dr. Bhavna has already been introduced. She's also academically charged and has done her DM Medical Genetics from AIIMS, New Delhi. So we begin with our panel. My first question to Mrs. Vandana. Ma'am, thank you for being here. We want to ask you that we have a very robust program for thalassemia. Where was the need to have this special program for hemoglobinopathies? Why was this introduced?
Thanks so much, Dr. Rima, for your question. And at the outset, I would like to thank the Society for Fetal Medicine to invite me. I'd like to begin with a caveat. I was in the Health Ministry till September 2021. And subsequently, I proceeded to do my MPH from Johns Hopkins. So I will reference whatever I say with respect to this period that I was in the health ministry, which was from 2015 to 2021, September. I'd also like to thank my fellow panelists for having me as part of this panel. In terms of the first question that you asked as to why was this program really launched, so the primary objective was to have a comprehensive program that would cover all hemoglobinopathies and not just thalassemia. So this would cover sickle cell disease and also other hemoglobinopathies, especially because the burden was high and because of the intermingling of the parents who were silent carriers. We were having children who were having very, very severe disease. So we felt that this entire issue needs to be addressed holistically. There was a huge burden on the affected families as well as on the state governments who were managing these issues. The primary purpose of a new guideline, which was launched in 2016, really, a comprehensive guideline, was to see if it was possible to prevent the births of affected children through comprehensive screening, both at the ANC stage as well as the newborn screening, which was done through CBC, and then confirmatory tests were done at tertiary hospitals. So if you have to understand the way our health system is organized, we have a lot of primary care facilities, the PHCs and the health and wellness centers. And then we have the community health centers and district hospitals, and then we have the tertiary hospitals in government as well as in the private sector. So that is how the screening was organized. And obviously there was elements of counseling to the parents, and then the entire aspect of treatment and management, which were organized at what we call the ICHH, the Integrated Centers for Hemoglobinopathies and Hemophilia, which were largely at the district hospitals. Overall, the purpose was to provide a better future for the patients through a comprehensive treatment. And another aspect which was not spelled out in these guidelines, but which we tried subsequently was, which is not true for sickle cells because the BMT is possible now, but in those days it was not there. But it was possible for other hemoglobinopathies. So we contacted certain public sector undertakings like Coal India Limited, who helped us to provide the funding for taking up bone marrow transplant for very, very needy patients. Similarly, it was a package was available under the Rashtriya Arogya Nidhi, which is a program of the Health Ministry to help people in dire need with financial assistance to undertake tertiary level procedures and surgeries. And under the Ayushman Bharat PMJ also, there was a package for covering the treatment costs. Subsequently, these are details I have collected from subsequently from some experts because, as I said, I was there till September 21. Subsequently, a very ambitious mission for sickle cell disease was launched in 2023, which was inaugurated by the Honorable Prime Minister. I'm sure Mr. Giri will be able to throw much more light on that. But it was primarily done because sickle cell disease also has its own challenges, especially its management in very remote areas. And the focus was obviously tribal areas, and that's why this big initiative was launched. And the aim is to reduce the burden of sickle cell disease by 2047. It's a multi-ministry initiative. Multi-sector collaboration is the key to this, and this was launched subsequently.
Thank you so much, ma'am, for those inputs. And I think the need was that there was a lot of social and financial implications of this disease that did promote our government to go ahead with so many plans and to launch this program. So we know the prevalence. Dr. Bhavna has discussed it, that we have it all over the country. It's just not the areas that are marked in red, which is Rajasthan, Gujarat, Maharashtra, Tamil Nadu, Orissa, and Madhya Pradesh. But the prevalence goes on to 17 states out of the 28 that we have in our country, which is a phenomenal burden of the disease that we really need to handle. And I think that's the reason, Vandana ma'am, that so much the government has gone ahead with this program. And she also mentioned that this was launched in 2023 by Honorable Prime Minister, And of course, the tribal population is important because we have a huge burden of this tribal population, about 67.8 million across Indian states that need to be looked after. So my next question is to Dr. Kaustubh, is that what is the burden of this tribal population as far as the sickle cell disease is concerned?
Yeah, thanks for the forum, for providing me an opportunity to share the views with this illustrious panel. And with respect to your question, as already has been stated, that the objective of the this very comprehensive scheme that has been launched in July 23 for with an ambitious target of eliminating the sickle cell disease by 2047. The prevalence, as you mentioned, is really high amongst the tribal population, and the considering the socio-economic status of the tribals and the nature of the disease, which is a very the transmission is through genetic predisposition. So it was really important that the because these are the most vulnerable population group, one of the most vulnerable population group in the country, and that's why this ambitious scheme was targeted so that these population can be saved from this burgeoning diseases. One of the main factors that we are looking for is to try to eliminate the prevalence of the disease by doing the emphasis is more on genetic counseling, so that the future generations are not affected by it. And obviously it also encompasses the challenges of management of the prevalent diseases and the complications, but the emphasis is more on awareness and genetic counseling, so that the prevalence of these traits and the disease can be eliminated in future.
Thank you, Dr. Kaustubh. So we understand, Dr. Vandana and you both have said that the guidelines that have been issued by the government, which were released in 2023, and they provide a blueprint for action by highlighting the key domains and the strategic recommendations to improve sickle cell disease care, and where each stakeholder can identify and implement specific strategic recommendations. So this is a very, very important document that has been released, and it's a very elaborate document that you must go through regarding dealing with sickle cell disease. So we understand that the goal is to eliminate the sickle cell disease as a public health problem by 2047. But how do we get there, Dr. Kaustubh? What do we need to do to get there?
As I said, the disease is prevalent mostly in the tribal population, and the significant step that we are emphasizing is on creating awareness. We are trying to import the importance of the counseling amongst the predisposed population. We are trying to do as much as screening as possible. uh, the target that we have been assigned by the ministry is that within 3 years we have to screen around 7 crores of population in the 17 highly prevalent states, and we have to put them on the management protocols as soon as possible. And the scheme also envisages that we have to distribute these sickle cell cards, which demarcates the genotype of the patient, so that wherever there is a scope of marital counseling, so it will be easier for the citizens to take a decision and to anticipate whether the progeny will be a sickle cell trait carrier or a disease patient. So the main emphasis is on creating awareness, counseling, and treating complications, and hopefully to avoid them altogether by the end of the mission.
Great. Thank you so much. So I think the government is building up on every level. It's the primary, secondary, tertiary, every level, not just screening, but even the treatment for the sickle cell disease patient, every level is being strengthened. So my next question is that how can we utilize, Dr. Vandana, how can we utilize the other platforms that we have for the health system? Are they being incorporated into the sickle cell disease program as well? I think you mentioned that. Could you just reiterate these points for us, Mrs. Vandana?
Yeah. So, I would start with the general point that it's not enough when we are trying to tackle a problem as large as this for only a response from the health sector. It needs a complete multi-sectoral collaboration, and that is an integral part of the sickle cell disease mission, which has been launched by the government in 2023. So all ministries which have touch points with the population, whether it's the women and child department through the Anganwadis, or it is the education department where the school children are there. So all these departments are also involved as part of this mission. The very important Ministry of Tribal Affairs is a very important partner in this entire mission. So I think one is to basically get everybody involved, and as Kaustubh said, creation of awareness, getting people to get screened. That is very, very important, and therefore the idea is to get everyone on board and get the population aware, get people to be screened, undergo counseling, treatment wherever needed. Now, I'm just going to go through these, some of these points that you have put on the slide here. Rashtriya Bal Swasthya Karyakram is a very important program of the Ministry of Health, under which screening of children is taken up at the Anganwadi centers, where children and also it is undertaken in the schools. So that's a very important platform for the screening of children at school level. This screening has also started, and as Kaustubh was mentioning, screening is a big part. My information is that out of the 70 million, 20 million screenings have already been completed, including the school screening. Pradhan Mantri Swasthya Suraksha Yojana is actually a big scheme for setting up aims and strengthening of medical colleges, which play a very important role when it comes to the tertiary care and the treatment for people affected with sickle cell. Anemia Mukt Bharat was a program launched by the ministry basically to try and reduce the anemia prevalence, which was quite high in the country at that point. And one of the elements of Anemia Mukt Bharat is also the convergence and looking at pockets where anemia levels are very high, and seeing whether it can be correlated to malaria. I was hearing about malaria in the previous presentation, or to hemoglobinopathies, and one has obviously seen overlaps in the high anemia areas and also the prevalence of sickle cell disease. Telemedicine facility is a very important platform of the government. E-Sanjeevani is the IT platform which is used to connect the periphery or the primary healthcare centers and health and wellness centers to higher level hospitals, whether it is district hospitals or primary health centers or the community health centers. So this kind of a facility is extremely useful in terms of management and treatment of people, because at the primary level, through the telemedicine facility, the facilities at the periphery can consult higher level facilities for the purpose of treatment. Even prescriptions can be provided through the telemedicine facility. So I think this is how the entire program is largely structured, that wherever possible that this convergence with existing programs can be taken up. One more initiative of the government that I would like to talk about, which has a bearing on a lot of people who are present today, is about the CRISPR and the gene editing technology. So the Department of Biotechnology is also working on that, where India is developing its own indigenous technology, and that can also be a big game changer as far as this field is concerned.
Thank you so much, ma'am, for those wonderful inputs. I think the government is really, really working hard, and we should be there by 2047. Even this tribal school, even the schools are being used for this platform for sickle cell disease elimination. And what I understand is now we have sickle cell disease as one of the 21 benchmark disabilities under the sickle cell disease, which are eligible for free education, reservation in government jobs, higher education. So this is, I think, a phenomenal move that has happened as far as sickle cell disease is concerned. Dr. Kaustubh, how is that you adequately utilize the resources that you have and the technology that you have? I think Dr. Vandana has highlighted a lot of those points. So how would you want to present it? That how do you merge human resources with technology to get the best outputs as far as dealing with this problem is concerned?
Yeah, with respect to the resource utilization across the various resources like human resources or technology, the Indian public health service delivery system is designed in such a manner that the nearest facility that the community engages with is the health and wellness center at the sub-center level, which is at the arm level. Uh, because the prevalence of the disease is mostly amongst the tribal population, the population norms for establishing a sub-center is around 3,000 per 3,000 population, one sub-center is constructed. Besides that, the ARSHAs are the community participants who propagates and who are the basically the backbone of the our primary healthcare delivery system. So the community mobilization and engagement with the community happens through the ARSHAs, and as Vandana ma'am has rightly pointed out, that the telemedicine facility, the e-Sanjeevani facility, is really, as we have seen in the field, is a game changer right now. It provides an opportunity to a very remote area to connect with the specialists in the cities or in the hubs, and to get the consultation done, which saves lots of resources in respect of time, money, and so it has an overall bearing. The government of India is trying to leverage technology and to deliver very quality service to the citizens of the country. So that way we are trying to optimize the resources and try to leverage technology and provide services to the citizens.
Thank you.
Similarly, the same thing applies to the sickle cell also. So we are trying to undertake mass screening and opportunistic screening also. Try to identify the sickle cell traits or the diseases, and try to do counseling and provide hydroxyurea to the persons who are suffering from complications or who are suffering from any debilitating issues.
Right. Thank you so much, Dr. Kaustubh. So I think work is happening at every level. Could you just give us a little input on how much the government is investing as far as the money is concerned on this project? I think it's huge.
Because the message has come right from the top that this is the vision of the Honorable Prime Minister. So resources are adequately allotted for trying to achieve the aim and objectives of the scheme. And as you have rightly pointed out at the screen, also you have shared the screen. This is the amounts that have been allotted, but this is not limited to this amount as you have displayed. The National Health Mission has the flexibility, has given the flexibility to the states. So the procedure for allotting the resources in the terms of monetary help that the center provides is very flexible. The states demands the amount of money with the expenditure plan to the government of India. It is undertaken a scrutiny at the national level, and the approvals are provided to the states. So because it's a part of the primary and secondary healthcare issue, so much flexibility has been given to the states so that they can design the problems according to their own needs. The solutions they can design as per their own needs.
Thank you. Thank you so much, Dr. Kaustubh. So, Vandana ma'am, just one last question to you. And you already, I think, pointed out that it's an integrated approach. It's just not the Ministry of Health, but I think it's across, I think, all your ministries, whether it's Ministry of Tribal Affairs, Ministry of Women and Child Development, Social Justice, Education. I think they're all there in this program. Would you like to just give your final comment on this, Vandana ma'am. I think we've lost her. Hello? Yeah,
So I think your
yes,
slide
yes,
here
ma'am.
captures very well the various stakeholders involved, and the roles and responsibilities of each of them are very, very well defined. So for example, as I said, awareness and screening, a whole lot of departments which have touch points, whether it's education, women and child health, their tribal affairs, they are very importantly engaged and involved. Ministry of Social Justice Empowerment supports a lot of hostels, especially for the tribal population and other weaker sections. So they are an important stakeholder in this entire thing, in this mission. Ministry of Tribal Affairs is setting up centers of competence as part of this mission. So in that way, various stakeholders' roles and responsibilities have been well defined, as it's a very important national mission. I would like to just use this opportunity to appeal to all the participants today and the panelists, because you all, are very important professionals and very important for this entire mission. So as part of your work, I would request you also to generate more and more awareness, to get people to utilize the various services that government is offering, whether it's a screening or it is a treatment packages through the National Health Mission or through the Ayushman Bharat PMJ initiative. Come forward, become part of the National Digital Health Mission of the government, where even the private sector facilities get registered, and the PMJ can they get empaneled, and people can avail the services from private sector also, because sickle cell treatment is covered under those packages. And my last request would be the newer and upcoming technologies like BMT, if more and more hospitals can provide even in the private sector, I think it would go a long way in the success of the very ambitious mission that the government has launched, which Kaustubh has also elaborated in great detail. Thank you.
Thank you so much. Thank you so much, ma'am. These were really wonderful inputs. I think from here, from the government aspect, we now move on to the most important thing that Dr. Kaustubh and Mrs. Vandana have been stressing is that screening is very important. So my next question is to General Velu Nair. Sir, what do you think a screening program should be? How to get the most effective screening program in place to catch them all and catch them early?
Thank you, Dr. Reema. Am I audible?
Yes, sir.
Thank you very much for putting this together. I'd like to thank you. I'd like to thank the Society of Fetal Medicine, Dr. Ashok Khurana, for actually having made this possible. And before I go on to the topic itself, I'd just like to recap a few important things which have been said, which are so vital. I've been part of the government for 3 decades. I retired as the DG, Director General Medical Services Army, and we had lots to do with hemoglobinopathies, because the first thing was, when I was a colonel, I was called to the parliament for answering a parliamentary question saying, why should not sickle cell traits be allowed to join the army? And if he has, why are you boarding him out? Why you ask him to go home? So there were a whole lot of people who stood up against us, saying the sickle cell trait is compatible with life and he should be allowed. And today we know, and I'm talking about this in 2007-8, and today in 2024, we know why he should not go to high altitude. Because he can have a splenic infarct, and he can have an acute chest syndrome, even if it's a trait. And we have published cases in our journals and foreign journals saying why we should not. So awareness has now come a whole, I won't say a whole circle, but we are there. We are there to a larger part of the circle. That's one. And second thing is, it's exciting times to be a part of not only fetal medicine or hematology. It's exciting times when the government actually is very proactive. Because when the government is proactive, there's a top-down approach. And when there's top-down approach, the pie is big. And when the pie is big, you can actually make a grab for the stake that you are capable of doing, which so many of us are. And we have talked about it, but implementation is the key. You can have any program, the success depends on the implementation. And that's what I think this government should be credited with, that the implementation is being audited. There are tools to audit. That's one. Second thing, promotion of public-private partnerships, which has come a very, very big way. Reema, I'm diverting a little bit because this is very important what I'm saying, you know.
Yes.
So
Yes,
with
sir.
your permission. And I would just say that we got think tanks, we got NGOs, like Dr. Vandana said, Coal India, BMT. BMT is not new. BMT is reasonably old. We started our first BMT done in 1983 by Tata Memorial Hospital. And the third transplant was done by Army Hospital, by us. We have come a long way. There are 120, 15 or 20 centers now, and we are doing a large number of transplants per year. But what's important is the government has joined the initiative to actually set up centers in various states. As you know, health is a state subject. Having said that, but hand-holding is so important. So here comes the role of the central government and the state government collaborating with each other, and the NGOs actually pipping in with the advances in technology. And technology, as you know, the private has taken a lead in many spheres, whether it's gene therapy, transplants, and a few others, which I will tell you. But definitely, this is exciting times, and I'm very happy to be here. And before I start my topic per se, one important sentence I like to say is, just like we said, Dr. Reema said, Ministry of Health, Ministry of Tribal Affairs, and multiple interagencies are taking part in this particular project, which is actually such a large project, which is going to see its effects maybe a few decades downstream. But having said that, we as doctors have the same duty. We need a multidisciplinary approach, which very often is forgotten. I'm a hematologist. Reema is a fetal maternal medicine specialist, and what you can have a whole spectrum. But the problem is, do we have enough crosstalk? And the crosstalk is what's going to take us to the next level. We must have the crosstalk. And so in the armed forces, we have created a multidisciplinary approach. We have multiple specialists, from hematologists, gynecologists, blood transfusion specialists, genetists, counselors, and what have you. But the need of the hour is multidisciplinary approach. And I must thank Dr. Bhavna Agarwal, Dr. Kausab, and Mrs. Vandana for having put things in perspective. Many things I'm going to say, maybe a little bit of duplication. At the cost of duplication, it amounts to reiteration. So those are the important parts. I'll skip what I don't think need to be reiterated. Okay. So the first thing is, can I go to the last slide, Reema? I think they've skipped a slide. Yeah. So the roadmap for screening is, the mission that we have set up is screening the population of up to 18 years in high endemic, we've said group A, B, C, D, depending on the prevalence, and you go, in that priority. Ultimately, we are looking at 40 years up to, 2047. But definitely, we start priority 1, 2, 3. So that's the first thing of screening. And 2 is the remaining 18 to minus 40 will be done downstream. And 3 is integrate this with the RBSK program, which has already been spoken about. And 4th is integrating with the other programs of hemoglobinopathies. So, duplicacy should be avoided. So now we have softwares. The same project is done by 5 centers, and the exchequer's money is spent. So we must have the software to prevent duplicacy. And that's one, we must have an independent agency doing that I find is lacking in many parts of the public and the private, both. And then we have, integrated existing strategies to be leveraged from various healthcare facilities, which we will just tell you. Next slide. So here you can see that for effective screening, we need a facility. And this obviously has to have the basic facilities at the community level. From the primary health center right to the district hospitals, we must set it up. And obviously, we are talking of pregnancy today, so let me restrict myself to antenatal screening. So from first trimester onwards, we must actually take them on board. And then we talked about, there has been a lot of talk on prenatal screening and universal screening of the newborn, which is a project which is being action in hand, but which is so, so important. because I think that needs to be reinforced at all levels by way of health education and awareness, so that they come forward for the screening and don't have taboos around it. And for this, we also know the family cascade. You have a case, you have a carrier, or you have a homozygous, sickle cell anemia or sickle cell disease. You need to have the cascade screening of the family members so that you pick up the other members who are carriers or otherwise. Okay, and you must actually dedicate and train these teams at the community levels. We have done that for different diseases. That's not easy. It's more easily said than done. So you have to have a top-down approach to train these people from community levels to district hospitals. Tertiary care is fine. So, that's when the fire is already there. You're extinguishing the fire in terms of a bone marrow transplant or a gene therapy. Let's see whether we can do it before that. We can prevent it. COVID taught us the importance of community medicine, public medicine, public health care, which is neglected by most of us in MBBS, MD, because we think, oh, it's such a boring subject. It's not. It's a savior. It saves our lives. And COVID, you can keep repeating it, was the prime example for this. And I was the scientific advisory committee of National Institute of Virology. I was the chairman for the 5 years through COVID from 19, and I'm still the chairman. But I must tell you, what we saw was the more you get public health co-opted into your healthcare system, the better you can deliver the preventive aspects. Whether it's vaccination, whether it's various modalities. When life is at stake, everybody comes on board. When life is not at stake, when only health is at stake minus life, you take it casually. Morbidity is neglected by us. So I think there is a point here for us to learn that public health should be learned by all of us as clinicians. Can I have the next slide, please? Okay, now there are two important documents I would ask everybody to read. And this is the National Sickle Anemia Elimination Mission, referred to already, but basically modeled to tell you what you should be doing till 2047 to achieve what we are talking about. Then there's another document which we have created in the National Hematology of Indian Society of Hematology, which is called ISHBT. It's a very comprehensive document published by the Indian College of Hematologists, which actually covers all aspects, and they are cross-referred and they supplement and complement each other. So both these documents, if you have a complete reference for our country. Next slide, please.
So thank you so much, sir, for these wonderful inputs. We would now want to know that which is the best method of screening. Dr. Bhavna did tell us about, but when you have to do mass screening and so many people are involved, which is your best method that you would select for screening the population?
Thank you, Rima. So actually, when you're doing community level screening, it's screening. And screening should be fast, turnaround time should be fast, reliable, reproducible as far as possible, and cheap. These are a few requirements, okay? And this is time immemorial. Solubility test. He never got a Nobel Prize who actually invented this. The high-tech molecular medicines and everything, the jet set guys, the fighter jets gets the Nobel Prize, but Wright brothers of 1903 didn't get a Nobel Prize, okay? Who invented the plane itself. So I would say a solubility test is the screening that we still use at the level of camps, communities, gatherings. And you can see in this picture that I've shown you below, right bottom, if you have a reducing agent in this fluid, if you put a drop or two of blood, you actually will have reduction taking place in the RBCs, and the deoxy hemoglobin polymerizes, and as a matter of fact, turbidity arises. If you see the first and third sample, you will see that they are turbid, but the second and fourth are clear. So a solubility test says positive, saying yes, but there are false positives and there can be false negatives. So a positive here needs to be confirmed. And confirmation is by point of care testing, which the GOI, Government of India, has now cleared. There are a few tests, if you see, at the level of electrophoresis, HPLC, and various types of electrophoresis, right from district hospital to the tertiary care. So you need to confirm this to say, yes, indeed, this is a sickler. Can I have the next slide?
Yes, sir. So I think what you spoke about, this multidisciplinary approach, we as obstetricians would always want a hematologist to guide us when we are dealing with a sickle cell patient, to steer the wheel. So what about the preconception care? What are your expectations? How would you want to go about? What about hydroxyurea? Can we use it in pregnancy?
Hematologists are a rare breed, but what is available is totally available, let me tell you. Okay, so me included. So let me start with hydroxyurea. This is old wine in a new bottle. Okay, old wine in a new bottle. And why do I say this? Hydroxyurea has been around for decades for various purposes. It basically is anti-proliferative. It sort of cuts around cells which proliferate. So in sickle, basically it has a different mechanism of action. It increases the HbF levels, like Dr. Bhavna and others have said. You have more HbF, it mitigates your effects of a sickler because your HbA is deficient. So if you can compensate with HbF, you mitigate the effects and thereby reduce all the deleterious effects from vaso-occlusive crisis to hemolysis to what have you. So that's the first thing. Second thing, the taboo around pregnancy. Anything teratogenic, as I was taught in my MBBS, still holds good. Still holds good. I'm sorry, this phone has gone on its own. It's gone on. Let me just put it off. I'm so sorry. Okay. To tell you that that hydroxyurea teratogenicity has been taught to us long ago. And as we know, organogenesis in the first trimester is at its peak. So people have tried various things in rats and mammalian cells to see what could be the effects. And we got a spectrum of effects. Embryotoxicity is what we are scared of. But, trials in non-human primates like monkeys, mammalian cells ex vivo and rats have shown if you use the dosing that we use, which is 15 to 30 milligrams or 35 milligram max per kg per day in divided doses, the levels in the amniotic fluid and the embryo is actually acceptable or negligible. That's one. But having said, let me underline this 3 times. You can't use it in pregnancy. So I'm just telling you where the research stands and where is the dictate. The dictate is right now we do not use it. Let me make it very clear. However, what we use supraphysiological doses, we've used 100, 200, 300 milligram per kg body weight, and we got teratogenicity. But that is known everywhere. And rats not equal to human beings. So what we've seen in non-human primates is very different from what we've seen in rats. So the embryotoxicity was much lesser in the non-human primates like monkeys and the mammalian cell cultures than compared to rats in terms of levels in the embryos and the amniotic fluid. Having said that, let me clear all the people who are on this platform as form of an audience. You are not supposed to use hydroxyurea as of now in pregnancy. That, let me underline that. But the science behind it, I've told you. And can I have the next slide?
And what about the other drugs, like the chelating drugs and folic acid?
Yeah. So the chelating agents are used because all our patients who are high risk are transfused. They're on a chronic transfusion program. Basically, a sickler who's homozygous can have anywhere 60 to 80% of HbS as his hemoglobin. A trait can have anywhere between 20 to 40. Usually around 30%. But you have got to decrease the levels by dilution. So you keep transfusing them because he's anemic. And if he's anemic, his growth is going to be retarded, cognitive functions are going to be affected, and it's going to have multiple organ affections, which is partly being told, partly I will tell you. But because of that, a chronic transfusion program comes on board. And every bag of blood you gives you 200 plus milligrams of iron. And your body has only 3 to 4 grams of iron. And iron, you cannot excrete more than, just 1 to 2 milligrams in a day. So what you get in terms of 200 plus milligrams is going to take you 100 days plus or 200 days to excrete. So iron is the most toxic, iron that you can have in the body as a free radical. So when your body does not want it for storage, it's a free radical. And the free radical can cause cardiotoxicity and multiple organ toxicities. And it is the, iron is the most abundant, metal in the planet Earth. But nature has made it so organically bound that you can't use it. So it cannot be absorbed by you when you take it also. So you are okay. In iron, people eat mud, people eat pica. Pica, when you have a craving for eating all odd things, that's for iron. But most of the iron is not available because otherwise many people would have died. So when you have a lot of transfusions, your iron overload can kill you, because you can have cardiomyopathy, you can have liver toxicity and endocrinopathies from thyroid to diabetes to others. Okay, so you need to chelate them. And the three chelators which have been used the world over are deferasirox, defiperone, and desferal. All three are available in our country at reasonably cheap rates. But in pregnancy, they're all teratogenic. We don't use them in pregnancy. So if a couple or a lady who's a sickler wants to conceive, we tell her, let's get rid of your iron. If your ferritin levels are more than 1,500 nanogram to the ml or 3,000, 4,000, you are in trouble. And that trouble we have to handle by chelation. So we tell them, please don't conceive, use contraceptive methods, but I must get your iron down. And when you use a chelator, you know what? Tell the patient, it'll come out in the urine, and especially desferal, the urine becomes orange. The iron comes out in the urine. So tell the patient, your urine is going to be orange, don't be scared. But you got to do that, and you have to do this over a period of time. And desferal is given as a subcutaneous infusion for 10 to 12 hours. And others are tablets, which are given, we have generic molecules, quite cheap, but you cannot give it in pregnancy. So you got to chelate, get them into as normal as possible, preferably below 1,500 nanograms, if possible around 1,000, so that the minimal effects of iron overload on conception, pregnancy, and whatever therapy you give thereafter.
Thank you, sir. So, and what about this vaccination that you need to give? Does it need to be given before the woman gets?
Yes. So as we know, I heard Dr. Bhavna referring to autosplenectomy. A young child with sickle will have a large spleen. It's engorged because all the bad cells, RBCs, get trapped there. So they have a large spleen. They can come in an acute crisis. You may have to do a splenectomy in a baby. But what happens is, because of this sludging, there's a lot of infarcts because the vessels get clogged and they auto-infarct. And many infarcts which occur ultimately cause the spleen to become dysfunctional. So functionally, you don't have a spleen. And so how do you see peripheral blood? Just see for Hobble-Jolly bodies, which the pathologist will report as additional findings in the RBC. If you have Hobble-Jolly bodies, your spleen is not working. You don't need any complicated tests to say you have a dysfunctional spleen. And if you have dysfunctional spleen, you are prone to encapsulated bacterial infections. And amongst them stand out the Streptococcus pneumoniae, the meningococcal meningitis, Haemophilus influenzae, and of course the viruses which are unconnected to the spleen, which is the hepatitis group of viruses. So we must give all these vaccinations, and we have the childhood vaccination program by the IAP. The adult program has been published by the API. So we have two country-specific programs which you can just look and just follow and give it. And you must give it even if you want to do, suppose you have to do a splenectomy for whatever reasons, you must give at least 2 weeks before you end up doing it, because you can have life-endangering pneumococcal pneumonia. So you must put them on this and a prophylactic of tablet penicillin / azithromycin till he gets antibodies, which can be up to 2 weeks. So that's how we bridge it. But we give all these vaccinations before we actually think of conception, before we think of a splenectomy, before we think of any procedure.
Thank you so much, sir. But yes, the real challenge is when we get a patient with sickle cell disease, and now we hand the patient over to you to guide us as to what are the challenges and nuances of managing these patients, what are the complications we are expecting, and what maternal and neonatal complications we are looking at.
So firstly, it's a nightmare. Secondly, it's a pleasure to treat these patients because they're so motivated to have the baby. So the couple is very motivated, and people like you all, from your specialty, give us full support. And we usually 8 or 9 out of 10 succeed in doing what we want to do. So the interplay between sickle cell disease and pregnancy, basically, you see the sickle cell disease side on your left. Hemolytic anemia will carry on, pregnancy or no pregnancy. Vaso-occlusive events will occur. You have to treat them. Chronic inflammation, because, whenever you have hemolysis, they release free radicals. And it's an inflammatory state. You do the CRP in these patients, will be high. So if you have an inflammatory state of chronic inflammation, not only is a chronic anemia, besides hemolysis, you have a chronic anemia of chronic disease, which comes in. Okay, and it affects all the other organs from the liver to the kidneys. And then you have functional asplenia, so you're prone to all the infections. Hopefully, we have vaccinated them. But many of our patients come from the villages with pregnancy first time on board. Okay, and here I must tell you, so many patients because 2/3 of our population in villages, their awareness is still low, so they get pregnant. And a patient of sickle, I've had cases, is already on hydroxyurea. They conceive. They come to you when pregnancy, morning sickness occurs. When they come to us, we say, oh God, you're pregnant. And you've been taking hydroxyurea for 2 months. What do we do? So luckily, there's a large study for 15,000 odd patients from the US, from North America, where they've shown that for whatever reason, accident, awareness, not having accessibility, people on hydroxyurea got pregnant. And if they got pregnant, what are the effects? And they found even the time of exposure may be short or long, but teratogenicity in forms of malformations was not very apparent. What was more apparent was stillbirths, prematurity, and low birth weights. So that still we deal with, So that was a real world data which helps us to say that it's not as much as a villain as we make it to. But having said that, as of today, no hydroxyurea in pregnancy. I'm just underlining to be careful. Okay. And then the last but not the least, my pet subject, venous thromboembolism and arterial thromboembolism. Pregnancy itself is a thrombogenic physiological status. And sickle cell disease compoundly adds to this thrombogenic status. So, you know what? The main problem is the placenta. In this, when you have the placental insufficiency, is because there are recurrent infarcts there also. And the recurrent infarcts is because they're thrombogenic. And, as it is, the sickle cells are sticky. They get the platelet cascade also going, and the venous cascade going, and there will be venous clots, there will be veno-arterial clots, and there will be multiple infarcts. And that is dreadful. And that can occur in various organs in the body. And when it occurs in the lung, you have an acute pulmonary syndrome. And if it occurs in the heart, you can have pulmonary arterial hypertension, which can actually make you a cripple. Then you come to the side of the pregnancy itself. I will just concentrate on two things. One is susceptibility to infections, and one is the higher risk of thrombosis. So when both these are there, you can't do a D-dimer, which is a marker pregnancy. It's high. So you got to see very carefully. Leg swelling is so common in pregnancy. So you may miss a thrombosis. So please look at these patients carefully. Do a color Doppler, and don't, false negatives and false positives are very common. Obese ladies are very difficult. So sometimes we have to do an MR to pick up a pelvic thrombosis, because these people need enoxaparin or a low molecular weight heparin to bridge them through pregnancy. Once they have that, your fetal loss can be very high. So you must prevent thrombosis in the mother, and surrogately, indirectly, for the placental sufficiency, and thereafter the fetus itself. So there are two things I'd like to draw your attention to. And coming to the next slide, please. So there's a slide before this we have skipped, I think, on maternal okay. So we've come to the neonatal or complications in the child, isn't it?
Yes, sir. So maternal, you've spoken about.
I've spoken about. Thank you. So like I told you, prematurity, low birth weight, IUGR, stillbirth, neonatal deaths, and all this can vary depending on the centers. The socioeconomic status of the family, the patient, is a large defining matter. What will be the outcome? An outcome in the primary health center in a remote, hilly terrain in Northeast versus one in Delhi or in a metropolis will be different. So don't go by these figures here. In a low socioeconomic country, the figures will be higher, will be bad. But when you come to the Western countries, they'll be better. So don't go by these figures. What is important to know is it all occurs. It's there. And it can be from 10 to 60% in different categories. But luckily, maternal mortality, the last slide, is not so high. Is documented, but not so high. Okay. So the next,
Right.
the next.
Thank you. So thank you so much, sir. But just a quick review on what test should we order when an antenatal woman comes to us.
Yeah, here basically all the lab biochemistry that we do routinely for all the organ function. In addition, we do LDH, which gives you the level of hemolysis. Okay, but definitely the urine analysis, which is very often neglected, is very important. Here, a microalbuminuria or a creatinuria should put me wise that there's a kidney involvement, which can really be troublesome later in pregnancy. So I really look at the microalbumin and tell the pathology, please have a good look at this. And a morning specimen would be useful. And then due to the serology for all the viruses, have a look at the eyes for ophthalmological proliferative retinopathies. Cardiac, it's a must to undergo echo. And neurologically, you must do a checkup because they could have had past strokes. All our sicklers have strokes in childhood, especially, so they can have cognitive dysfunctions. So you must get a neuro consult. Okay, and sometimes just do the blood iron profile. Many of them, different parts of the world, in our own country, different parts, from 20 to 50% can be iron deficient, despite having multiple transfusions, because of menorrhagia, because of various reasons. Okay, multiple pregnancies, some of them have. So you must look at the transferrin saturation. If that's very high, I'm okay. Leave it.
I would now like Rahul Kataria.
Hello.
Yes, sir.
Pardon?
So thank you so much for those wonderful inputs. We will come back with a few more questions. I wanted to ask about this transfusion, prophylactic transfusion, to Dr. Rahul Kataria, that how is it important to give prophylactic transfusion to a mother in pregnancy, and are there some different protocols that we need to follow? Dr. Rahul?
Yeah, thank you, ma'am. I hope, thank you, ma'am, and thank you, FSM, for having me here. As regarding this disease is very unique because in this disease, we tend to give prophylactic, long-term, acute, and therapeutic all kind of transfusion. And the purpose here is that we need to maintain the oxygen carrying capacity, but we also need to take care of the proportion of sickle hemoglobin. So in pregnancy, if the female is already on transfusion, we need to carry on the transfusion during the pregnancy. And the indication for this is that if the hemoglobin falls below 7 or there is a fall of more than 2 gram per deciliter, then we need to undertake a transfusion. Normally, these patients, when we over-transfuse this patient, they tend to develop hyperviscosity, which leads to vaso-occlusive events. So what we have to do, we have to maintain a hemoglobin of 10. That is considered the safest range, provided that the hemoglobin S goes beyond 80%. The patient are usually able to sustain when the hemoglobin S is less than 80%. But it is a normal condition. But when it comes to acute anemia, try to maintain a hemoglobin closer to 30%, hemoglobin S closer to 30%, because it will prevent those strokes. It will prevent the acute chest syndrome in these patients. And if you talk about prophylactic transfusions, when it comes to acute pain, I would say crisis, only prophylactic transfusion is beneficial, because if you have an acute pain crisis and you try to do a therapeutic transfusion, this won't help. So this is one thing where we advocate, if the patient is already of sickle cell disease, then we need to give prophylactic transfusion to prevent not only acute conditions of stroke and chest syndrome, but also prevention of pain crisis. And if we're going for, I would say, surgeries, normally the patient will be going for cesarean sections. In that case, hemoglobin of 10, HbS of 30 is somewhat manageable. And if the hemoglobin is less than 9 and the HbS goes beyond 60%, in that case, before I would say surgery, we need to draw down the hemoglobin S level lesser than closer to 30, then only we should move ahead with the surgeries. And as sir was talking about lots of iron load in this and lots of complication, we know that they are related to the complication of prophylactic, because they, from the very young age, the patients are put on transfusion and lots of iron. Apart from that, I'll take a leaf out of Dr. Bhavna's presentation. She was talking about that sickle tend to help in prevention, but it provides a protective layer against occurring of malaria in these sickle disease patients. So when it comes to alloimmunization, as a transfusion medicine specialist, we say that there is one blood group system, that is Duffy. And Duffy blood group system is considered to be anchor for malaria. So sickle cell patients tend to lack that antigen. So if there is not antigen, the malarial parasite will not be able to anchor on the RBCs and it won't go inside the red cells. But that is a protection. But what it does, when I give a Duffy positive unit to the patients, they tend to form antibody. So it's a two-way story. One way it is protecting against malaria, but in another way, it is causing an antibody formation in the patient. Apart from that, in Indian population, if you see the distribution of antigens, I would say that the natural nature of genetics is such so that the sickle patients tend to lack few antigens then. That is capital C, capital E, KID, Duffy system, and S. They are normally not, those antigens are not present in our sickle patient. But the blood which we give for transfusion, these antigens are in the donors. So it is natural, receiving those antigens, we tend to form the antibodies. And this difference may be not very large in India, but it is very bigger when we talk about the Western world, because the African descent people who have migrated from Africa to Caucasian dense areas. So the donors are Caucasian population and the recipients are African population. So there is a disparity between the antigen. That's why the literature reports that elimination is higher in Western world in comparison to India. But still in India, we tend to have 2 to 5% of patients having antibodies. So which is a big number. So that is all about where we can talk about the prophylactic transfusion.
Right. Thank you so much, Dr. Rahul. Those are wonderful inputs. So I think where it demands, we need to give transfusion irrespective of the problems that we have with prophylactic transfusion, like iron overload, reactions, infections, etc. But Dr. Rahul, any two, I think, what is the absolute indication? I think you already brought that about. So where there is, yes.
And the stroke is the only thing is that when we talk about stroke and acute chest syndrome, we need not only to focus on the hemoglobin levels, but also on the exchange. If your hemoglobin falls, I would say it is around 9, and there's still the patient is symptomatic, we need to go for a exchange. We can go for a automated exchange or a manual exchange, but we need to lower the sickle hemoglobin to 30% to prevent any of those things.
Right.
Hemoglobin is better considered when we talk about sickle patients management.
Right. Thank you so much, Dr. Rahul. Thank you so much. So I think we've been discussing that genetics is very important. We've had a lecture on that. So we know that it's a disease that requires genetic evaluation, prenatal diagnosis, counseling. So Dr. Bhavna, you've already stressed, we have understood that it's the point mutation that happens in our sickle cell, and that's how it makes it different from thalassemia. So I just want you to just interpret. This is a report that I want you to interpret and tell us that what should we do next if we have a child with sickle cell disease.
Right. So thank you, ma'am, for this question. As I have already told, and the previous speakers have told, that we see this HbS window. So we can see here there is a area which is 71%, 71.8. So anything between 70 to 80, it is a homo sickle cell. So as you told, it's a sickle cell disease patient. So it is a homo sickle cell, and there is no other D, C or other peak. So it is HBSS, right? And next would be definitely counseling for this particular child in terms of the acute and long-term complications and surveillance, and also at-risk members identification, their counseling, and if they're talking about reproductive options, so doing the testing of the parents, like we can see here, first we do always HPLC. In this, I assume this HPLC is of father or mother, either of them, and we can see the window here, it is showing 32.9, so it is into hetero sickle, which is called as sickle trait. So anything between 30 to 40 we take as trait, and we can see here that the molecular told what we were expecting. Both the parents were carriers of the HBB C.20A2T change, which is actually codon 6 change, which is sickle. So prenatal can be offered because the risk of recurrence is going to be 25%. I think, ma'am, you're mute.
Yeah, thank you. So I think we need to test the parents, we need to do molecular testing, and we need to know what is the mutation. That's extremely important. So you've already discussed this. I will not dwell over it, that it's just not the different patterns of sickle cell that can manifest, and the severity varies with the kind of mutation that we have. But I have this 19-year-old lady who comes, a young girl who comes for, she's from the tribal population, and she comes for counseling, because counseling is now a part of the government scheme as well. So how would you counsel this patient?
Right.
She's married and she wants to know her future.
So, ma'am, like we go stepwise, the algorithm is look at the HPLC, it is showing HbA2 of 4.3 and HbS of 71.1. So it is a suspect of HbS beta, which we have already talked about. So the variant which was identified was actually HbS, which is C.20A2T, which is one allele is showing HbS and the other allele is showing the most common mutation of beta thalassemia. So it was HbS beta combination. So now we know that the patient is having this and she came for preconceptional counseling. So like I mentioned, we need to check the spouse, the future spouse or the prospective spouse, about not just HBS. Like I mentioned, we need to rule out HBS disease, so sickle cell disease. So we need to actually check the spouse for any HBB pathogenic variant. So my message here would be not just check for HBS here, check the spouse for the entire HBB gene, because we need to rule out other hemoglobinopathies. And depending on what we find in the spouse workup, we will offer prenatal diagnosis.
Thank you, Dr. Bhavna. So this patient comes to Dr. Khurana. Sir, please, she wants to know what prenatal test can be offered to her. Khurana, sir.
Sorry. So obviously she's going to be interested in prenatal testing, and we have to offer her this at the right time. The question is, when we're looking for things like point mutations, are we going to offer her a CVS, an amniocentesis, or a cordocentesis? A cordocentesis would come too late in pregnancy, although it would be the best reflection of fetal blood, and therefore we would choose between a CVS and the amnio. And because our methods of analysis for a point mutation are now becoming simpler and simpler from a lab point of view, we could offer her any of these. There is no doubt that we don't have to worry. So honestly speaking, we just counsel her, make sure that yes, she has been appropriately tested, that the diagnosis has been reconfirmed with her, because she might have undergone an older test, which might even be a false positive, or it could be just a screen rather than an actual HPLC. We confirm that. And we also like to confirm whether there's any other associated hemoglobinopathy, like we see so frequently in this, like a beta thal on both sides. So then we like to be extra careful about that, but any of these could be offered. There is, of course, also the new test that we were discussing earlier, which is coelomic assessment. We used to do coelomic evaluation, the extraembryonic coelom, and put needles in it in the 1980s, and we used to do that transvaginally. And then we shifted on to this being done for some conditions, theoretically pretty much positive. But the problem was that the amount of actual material that we got from this was very little. And so coelocentesis did come to a stop. what we have realized now is that from a diagnostic point of view, we have shifted over to our CRISPR Cas9 system so that the point mutation can easily be picked up. And that is important. So we have understood that, yes, because we now have an SNP chip for this, which is becoming available and has been approved for clinical use in the West, it might be possible to actually make a very, very early diagnosis. The only question is that it would require so much skill that we probably can't do it on a public health basis. So we would still be depending on our CVS, and but technically, the question is how much can we make a CRISPR-Cas9 available, or the SNP chip available for general use. There is no question of it being offered on a government platform because our priorities have to be different. And we will, of course, evolve these as we get closer to 2047. But in the meanwhile, if those companies that are actually offering this test as available for patients, if we give them a tax holiday on other aspects of genomics, that means that the income from other aspects of genomics would be covered by a tax holiday, then we'd expect them to spend that money here. So there would be a public-private partnership where what they save on taxes should actually be spent publicly on making available the SNP chip for this particular diagnosis. So that is where we're actually going to be sitting, and I think that's the way we will be going. And with this early diagnosis, it should become possible if there's lots of skill. Otherwise, it will depend on CVS. And while we're on CRISPR, may I also mention that because CRISPR is now available, we do understand also that the treatment that we're going to be using is also going to be on CRISPR, because one of the most widely discussed aspects of the CRISPR gene editing is actually in terms of sickle cell disease. So bone marrow transplant is going to be there, it would be there, but more importantly, this bone marrow transplant might be increasingly replaced by CRISPR-9, which we could use antenatally. And I think that would be really the answer in the future. Yes, there we are. And as far as this slide, Rima, we can't hear you, of course, but I'll carry on here. In terms of the availability of a pre-implantation genetic diagnosis, we do understand that with the prenatal genetic diagnosis, we perhaps may not be so perfect because it's going to be not simple technology, which means that our patients will have to go through an IVF before we can do this. So if they've had several pregnancy failures because of this, or they have a complicated thing like a sickle cell beta, then obviously we might actually consider this. Otherwise, I don't think it's going to be practical as yet to develop a PGD specifically for this. That's not going to accelerate us to 2047 anyway.
You're mute, Rima.
Rima, we can't hear you.
Still mute.
Meanwhile, if Dr.
Okay.
I can
So
take the
I'm sorry for this.
Now we
this
can hear you again.
technical
That's
glitch.
wonderful. Yes.
Yes, I'm extremely sorry for this technical glitch. So what about we have Dr. Girish Patel from Gujarat. We know that Gujarat is got huge number of sickle cell cases. So Dr. Girish, how would you tell us something about the statistics of disease in your state? And also antenatally, how would you like to follow up these patients? So Dr. Veru Nair has already given us a roadmap to move forward. Dr. Khurana has done the prenatal testing and she comes to you for antenatal care. So how do you take this forward?
So thank you, Dr. Rima, for giving us an opportunity to share on this topic, which was actually, after listening to all these stalwarts, I should confess that we were knowing nothing about this, no? I was not knowing about that even HBSS and the difference HBSC. So now, as far as the Gujarat statistics is concerned, in last census, which took place in 2011, there was actually 6 crore population in Gujarat. Out of that, if you consider the tribal population, it was 89 lakhs. Out of that 89 lakhs, 9 lakhs were the sickle cell trait. And true sickle cell diseased, they were only 70,000. Now, if you compare with the non-tribal population, if you see as a whole in Gujarat, beta thalassemia trait is 1.95% and sickle cell trait is 6.5%. But if you go in tribal area, beta thalassemia trait is only 1.7% and sickle cell trait is 11.4%. Whereas in non-tribal population, beta thalassemia trait is 2% and sickle cell trait is only 1.1%. So this is the statistics of Gujarat, and one newborn screening program actually which has taken place 5-6 years back. They have screened 5,500 newborn screening program they did from the 4 districts: Valsad, Navsari, Dang, and Surat. Out of those 5,500 babies, they found sickle homozygotes, 30 babies. Beta thalassemia trait were 687 babies. And 4,700 babies, they were unaffected. So this is the RIMA statistics for Gujarat. Now, as far as antenatally follow-up, you have told me to say about mothers who are having sickle cell disease and they become pregnant. Many things have been highlighted. Now, if you consider 2 sets of mother, one set who are already knowing that I am having a sickle cell disease, another population which will be caught up during the first time in the pregnancy. So the women who know that they are having sickle cell disease, at least one, nobody has told about the ophthalmology reference, no? Because these sickle cell mothers, they are also vulnerable to proliferative retinopathy. One, echocardiography for pulmonary hypertension. As Dr. Nair has already highlighted, complications of iron overload and iron chelation before pregnancy, and vaccination program because of the hyposplenism, and they are more vulnerable to infection preconceptually. Once they become pregnant, many complications which are common in this sickle cell mothers: severe anemia, renal dysfunction, pulmonary hypertension, stroke, acute chest syndrome, femoral avascular necrosis, functional asplenia, so many things. So we should register them first of all in tertiary care unit with an obstetrician and a multidisciplinary team having a knowledge about this disease, so that we can properly identify the problem at the right time and we can treat them. That is the all thing I just wanted to say, and many things have been told about this disease also.
Yes, I think multidisciplinary team and having
Yes.
moving together is what is important. So ultrasound wise, how would you want to follow up? Would you increase the frequency of ultrasounds for follow up, or would you just continue the way it is?
No, we should actually screen them little at a frequent intervals, because they are more vulnerable for the preterm labor and fetal growth restriction. So once woman is having complication, we must see the fetus also, that there is an impact of this complication on the fetus as well. So we must increase the frequency of the surveillance also.
Thank you, Dr. Patel. So now we have Dr. Chinmay from Pune. He would get us the statistics of what's happening in Pune or in Maharashtra. Dr. Chinmay, what is the sickle cell disease status in your part of Maharashtra, which again is endemic for the disease?
Thank you, Dr. Rima, SFM, and Khurana sir for this opportunity to be here. And so I practice in urban Pune, and Western Maharashtra and Pune per se is not really prevalent for sickle and thal. But because of the great national integration and so much of immigration into the Pune, say from Vidarbha area, which accounts for 70% of sickle cell disease load of Maharashtra, and similarly Gujarat and northern India. Now Pune has rapidly become a seat where we have got prevalence of around 3 to 5% of hemoglobinopathies. And when we go to our public infrastructure, this prevalence further increases to around 8 or 9% because more immigrant population goes to our public facilities in the city of Pune and PCMC. We work here as Umarji Hospital, and there is a charitable trust called Janakalyan Raktapedi. We've been working together for more than 30 years now. However, on the topic of hemoglobinopathy, especially sickle cell disease and thalassemia, when we started, so there was a thought that there should be a payback to the society, and what a blood bank can do is give blood. So what Janakalyan Blood Bank started doing a few years ago is they started a free transfusion program for hemoglobinopathies. So from their side, they would register thalassemia and sickle cell survivors, and they would give free blood, which is leukocyte depleted, irradiated, NAT tested, so best quality blood, to all these survivors free of cost every month whenever they need it. Slowly and steadily, we started seeing that the numbers were bulking up, and the numbers have now reached to around 300 bags per month. In one blood bank alone. I'm also associated with a couple of public hospitals here where we've got around 350 and 300 bags going out. I mean, registered patients with these places. So around 1,000 out of 4 institutions. So that much is the workload now. And then there was a thought process that we need to further understand and help these patients. So as Karnar Velu said, as an NGO, we have been helping out to some survivors with bone marrow transplant, but then you have to do it very judiciously. You need to know that this money is not going in vain because these are huge costs. So what we do is we usually try to choose a survivor who is less than 7 years, at the most 9 years. And as Kuran sir beautifully showed over there, what we are also trying to think on the lines is that can we not detect sickle cell before embryo transfer, and also maybe do HLA typing so that you can potentially get a donor for the survivor, for which we want the age of the child to be, the survivor should be less than 5 years, so that when this child is born and later on, hopefully we can do it. But we need guidance, and I'm sure the authorities here will help us figure out what is the best public way of doing this. Last but not the least, the prevention, taking it a step further. Recently, we have launched a thalassemia screening program for the public hospitals, one of its kind. So we are doing positive patients partner testing and CVS HBB gene sequencing for free.
Great. That's fantastic work that you're doing, Dr. Chinmay.
Thank you.
Now this patient has moved from Gujarat to Maharashtra to you, and you have to deliver her. So any particular intrapartum or postpartum care that you want to offer?
So as the doyens before said that you would like to avoid blood transfusion as much as possible, and at the same time you will need to be ready for a blood transfusion. So sometimes with the help of hematologist, use of erythropoietin can sometimes be helpful. Not in disease, of course, but with trait patients, you can judiciously use it and avoid potential blood transfusions. We would love to offer an elective birth, and in my experience, I've seen these patients also have concomitant gestational diabetes, maybe because of repeated injuries, maybe because of genetic structuring. So they have gestational diabetes. So the balance will be of what her hemoglobin level is, her cardiac status, and the other aspects. Of course, like any other pregnancy, you would prefer natural birth if possible, and vaginal birth will be preferred mode of birthing unless there is a contraindication. These patients being anemic are usually volume overloaded. So you want to restrict their volumes and at the same time keep an eye on their urine output. So usually we restrict it at around 80 mils per hour. Unless there are signs of dehydration. To avoid a crisis is very, very important. And unlike other cases, you would like to keep the room over here adequately warm and at a comfortable temperature for herself and the baby. Epidural is not really a contraindication, and it really helps with smoother processes. And also you can potentially convert it to spinal. I mean, in the sense you can give a higher volume and get a spinal-like effect if you had to convert the patient to a cesarean. However, what I'll be really interested in knowing is the growth of the fetus, because these hypoxic mothers may have slightly deranged placentation and thus smallish babies. I would love to monitor these babies continuously with electronic fetal monitoring. And at the same time, they should not be bedridden. So I would prefer a telemetry while I'm monitoring them. Usually I prefer to cross-match 4 units because although my blood storage center locally has blood, we want to be sure that we have adequate blood here. And I would also inform my mother blood bank that I have such a patient, and sometimes we may end up giving more transfusions. And of course, I think the prime most part of this is tender loving care. She's been through a lot all her life and the last 7-9 months. So you need to be there for her whenever she needs it. Thank you.
Thank you. Thank you, Dr. Chinmay. And I think for the postpartum period, any specific things, I think
Kanan Velu has already referred to it, and postpartum especially becomes thrombotic for these mothers. So you would want to give them low molecular weight heparin for 6 weeks at least. You would want to look after their hydration, give them dead stockings, make sure that they're being mobilized. And when they're going back home, again, it will be a good idea if you have somebody, say a paramedic or a medic, who can visit and make sure that the home is really comfortable. Sometimes, you know, their bedrooms and the traditions, they make the rooms too warm or too cold. So you want to kind of educate the elders in the family about her comfort. Of course, NSAIDs can be used routinely like any other case. And you would like to prefer breastfeeding in these mothers, which is a very good contraception till 6 months. But before that, she should opt for a really better contraception. And now with the advances of implants, which can also reduce the chances of intrauterine infections, we usually prefer the subcuticular implants as their preferred mode of contraception.
Thank you. Thank you so much for this care for this patient. And I would now request Dr. General Velu Nair to tell us that, sir, there are advances that are happening in the treatment management. We've had some discussion on the CRISPR gene therapy. Would you want to elaborate on this a little, since FDA has also approved of the CRISPR technique for management of sickle cell disease?
Sure. This short word called CRISPR has changed our lives and has changed the world for a sickler. And let me wish them all the very best on this very important day. We are talking about sickles today because we want to wish them the best and give them the best. I think we should reiterate that. So CRISPR is an acronym which stands for Clustered, Regularly Interspaced, Short Palindromic Repeats. Don't try to remember it. Just say CRISPR. So that's fine. And CRISPR Cas9 is the scissor. You know, it's the molecular scissor. So basically, in the DNA, when there's an abnormality, you want a scissor to cut at the point where you think there is a problem. There's a guiding RNA which goes there and says, cut here. So he cuts there, and then he actually gives you delivery of the product you want. So the products you want in a gene therapy are, do I want to replace a normal hemoglobin A, or do I want to get an HbF higher? And the common, easier one was getting the HbF higher. So that's the way the two approved products have gone, which is, you can put the slide up, Dr. Rima, on the FDA approved gene therapy. You know, there's a slide on it, on Casgevy, yeah. So that's the first product, you know, which has been approved. So, you know, here what happens is, as we know, the switch in hemoglobin, nature has switched hemoglobin F. When you become a baby and you start growing beyond neonate, HbA starts arriving. So HbF gets silenced. So the gene to silence it. So if I can unsilence him, I get the HbF back. So to switch on the silencer gene of HbF is the trick which the Cas9 is doing in these two products here. So getting the HbF higher, and once I get the HbF, it compensates, oxygen delivery occurs, my vaso-occlusive crisis decreases, my hemolytic crisis decreases, my whole morbidity and mortality decreases. So now we have these products in the shelf. From 1617, it started the research, FDA approved now. And as a matter of fact, these two products are available, but it's prohibitively costly. We are talking of 1.5 to 2 million per patient, US dollars. So obviously, we need our generic Hindustani version. So we are working on that. Like we know the CAR T cells, cost 100, cost $1 million. And, in India now, we are selling it for, 30 lakhs. And we've just done our first CAR T cell. It's a fraction of the cost. And it's an option between life and death. So obviously, even this with time, like HIV medicines and what have you, I hope for these patients, the cost comes down. So that's about the CRISPR technology. It's a DNA editing technology, which actually has now, I would say, been refined to a large extent. And now, of course, there are many players who are actually competing, and two have been already approved, as you've said. And Dr. Bhavna also referred to it. I would also like to say a word about BMT. I've been doing BMT for the last 30 years for sicklers. And we published our data. And, BMT has got certain, do's and don'ts, unfortunately. Younger the patient, better the result. If it's less than 5 years, I'm talking of 85 to 90% results. Older the patient, worse the results. Beyond 16, very challenging, because organ affection has taken place. There's a little bit of pulmonary hypertension, there's strokes. So, comorbidities dictates the outcome. So younger the age, lesser the comorbidities, obviously the better the outcomes. That was BMT for you. And the best results in BMT were when you have a matched sibling donor, or among many consanguineous marriages, it can be also, within your cousins also you can get it. But definitely the chances in a normal family is 25% of a sibling having 100% match. Only 25%. Okay. And now we are doing haplo, which is a 50% match, and between a haplo and a full match, we're doing transplants. But the results are not 95%. The results can be between 60 to 80%. But it's much more costly because you have to use a lot of drugs and a lot of complications. So that's about BMT and about the CRISPR-Cas. And as you know, we have been using monoclonal antibodies, which actually prevents adhesiveness of the RBCs on the red cell, on the vascular endothelium, which is the P-selectin. And with these monoclonal antibodies actually prevent the attachment, so prevents the pathogenesis. And then we have voxelotor, we have L-glutamine, which is antioxidative. We've used all this, but you know what, really speaking, they're all adjuvants. I haven't really seen a cracking benefit where I can prevent all these side effects or complications which we have alluded to. So really speaking, we have to go for a curative intent in a young child, which is either the gene therapy or bone marrow transplant. The rest are just adjuvants. Just two more things I'd like to say with your permission. And one is Dr. Chinmay referred to erythropoietin. So, EPO, as I told you, pregnancy is thrombogenic, sickle is thrombogenic, peripartum is the worst, and postpartum is the worst phase of thrombogenicity. Erythropoietin is thrombogenic. So please give it, but take precautions. Please give it. Plus, suddenly you'll have the patient getting dyspnea and may have a VTE. So point is well taken, but the caution is keep your eyes and ears open and tell the patient if there's a problem. And D-dimer does not help you. Yeah. So it has to be the patient, and leg swelling doesn't help you because all pregnant ladies, leg swelling is so common. So you really have to educate the patient on this when you use EPO. So I personally, it's a toss-up. If the patient in a rural area, I will give a transfusion and send her home. But if it's from the urban city, I will give EPO. So I would actually classify this as a socioeconomic strata. And and you both are right, but it's how you choose. In our country, that's so important. Then I also would like to tell you that this, we never talked about sickle cell trait in ladies who are pregnant, having symptoms and having problems. We talked about sickle cell disease and sickle cell anemia. But let me tell you, I've seen enough sickle cell traits actually dying. You know how my interest started when I started getting body bags from Sichuan Glacier. And I saw, and you know what? The first thing was there's a Maratha regiment there. Maratha regiment, and Marathas, as you know, the tribals, the Adivasis have a high gene frequency for sickle. And they're sickle cell trait. And when they are coming in, they are fit. They have good hemoglobin, good everything. So he was fit, he became a soldier. But he came back dead in a body bag. And we did a post-mortem, we saw acute chest syndromes. When we analyzed the PCRs, they were sickle cell traits. So a trait can have acute chest syndromes if he's a scuba diver, if he's an alp, if he wants to do skiing, if he wants to, be a soldier and go to the glacier. And that's why in the outset, in my opening statement, I said we were called for a parliamentary question on the fitness of THAL traits and sickle traits being a soldier. We said the moment we detect it, we will actually board him out. Then they said, why don't you screen him at entry? We said, not cost effective. Whatever you do has to be cost effective, because your money and my money that we are using, so-called the exchequer's money. Okay. And last but not the least, I want to talk about digital platform, which was referred to by Dr. Vandana and Dr. Bhavna. I want to tell you, there is a lovely platform which is called the Extension for Community Healthcare Outcomes, called abbreviated as ECHO India, ECHO. So I am the advisor for them for hematological disorders. It started by Dr. Sanjeev Arora from New Mexico for hepatitis B patients and hepatitis C patients, where telemedicine is an NEGM publication, where telemedicine can actually, deliver wonders. And we've done that in the army. And so I've taken up when they offered me this job as an advisor to them. Now we are collaborating with the state of Maharashtra, Madhya Pradesh, and West Bengal for eco programs for rural health to pick up these things by just health education programs. And it's a big success. And any of you can tap it. Eco India, if you tap, you got a website, go there, and it's all there. Coming to splenic infarcts in soldiers, we published our data in two very good journals, in the High Altitude Journal of Medicine and Blood. We have published our splenic infarcts in soldiers in these international journals to create awareness that all is not honky-dory just because you're THAL trait. You can't go scuba diving, and you should not go to the Alps to ski. Be careful. You should know the limitations. I think I've covered just everything except the last but not the least, TCD, mentioned fleetingly, transcranial Doppler. This is a very important tool used up to about 15, 16 years of age. And, it's an ultrasound non-imaging technology, which we can see the velocity mentioned by Dr. Bhavna. I'm saying at the cost of repetition for reiteration, because impending stroke. And if he's got an impending stroke, transfuse him. Get the HbS levels down. If it's 80%, get it down to 60% or 50%, and you'll avoid a stroke. And by avoiding a stroke, you change his life. So TCD monitoring is one of the government programs, and we must have it. And you must talk about it so that people are aware of it. With that, I think I've just about covered everything, I think, except one last thing, Rima, and that is a bug called malaria. Rima, you're mute.
So we've had a discussion on malaria, sir. I think we really thank you. We've really overshot our time.
It's okay. You overshot the time for a very good cause. So I think it's okay. We can have dinner half an hour late.
It was a wonderful discussion.
Yeah.
Really, really thank you. We thank all our panelists, everybody for being here today. And we really, all of us need to work together to get to this 2047. And we're really grateful for your wonderful input. Thank you so much for being with us today. Thank you.
Thank you. Jai Hind.
Jai Hind, sir. Jai Hind.
Jai Hind.
After a long time, we came to know a lot of new things.
Very well conducted,
So,
Dr.
Khurana,
Nima.
sir, if I could.
Very well conducted. I must congratulate
Thank you,
Dr.
sir.
Nima and her team, and of course, Dr. Khurana, her mentor, for having put this wonderful program together. And this is what we need.
Sir, and I think this is entirely Khurana sir's vision, that we have to get to the root grassroots level and work.
Very good,
I would
very
request
good.
Khurana sir to kindly, if he could say a few words, and we end the program here.
Yes, thank you, Rima, and I must congratulate you for putting such a difficult subject together. You know, we're treading a lot of new paths at the Society of Fetal Medicine for the past few months. And what we've always felt was that we do the beaten path, we discuss something that's already in the textbooks, discuss something that's new in our journal club, and then we seem to forget that we have a much larger duty to do. But this much larger duty will not happen until all of us work together. And it's not easy to put together a program like this. It's certainly not easy to get stakeholders from government to be here. And I must congratulate you for putting us all together. It's been absolutely phenomenal how we were able to get the inputs from Vandana ji as well as from Kaustubh. And that was really fantastic. We've also been extremely lucky tonight to have the presence of General Nayar. I have very, very poor knowledge of hematology, and I've always depend on a specialist for this. But I think now it sort of tells us that it's not impossible to work together and do a little bit of our own everywhere. And thank you, General, for helping out with this.
My pleasure.
Our new talent in genetics has proven that, yes, the younger generation is leading forward and really set the thing going. And this one single emphasis of the fact that whereas sickle cell is a point mutation and that thalassemia is a disease of many mutations of a gene has really been driven home, not only from a treatment point of view, but also from a future point of view. Because we do understand that, yes, they have the same outcomes, but sickle cell is extremely important because of the vaso-occlusive aspects and the deaths that we talk about. So these sudden deaths can certainly be prevented. I'm so glad we had Dr. Girish Patel to represent Gujarat, where this is such a major problem. And of course, Chinmay, who is always doing such marvelous programs for us in Maharashtra and putting all this together. I know that we had a lack of attendance relative to everything, but that's not the reason why we put these programs together. The reason we put these together is so that we have a bank of knowledge that will finally be available on the SFM YouTube channel so that anybody who needs to see this at their leisure can see it. So it's going to be a treasure trove for future generations. And I thank each one who's participated today for coming together to put this huge big bank of knowledge together on sickle cell disease. And I do hope we accelerate and we don't have to wait till 2047 to wait for the results. And that maybe by 2037, we might have results already, thanks to all the new technology that's pouring in. Thank you.
Thank you.
Thank you, sir. Good night. Good night, everyone.
Good night.
Good night.
Good night.
Thank you, Mohit.
Good night.
Good night.